Hit the subscribe button or visit us at auau.auanet.org.
Hello, everybody. I'm Judd Mao. I'm a urologist at Duke University Medical Center in Durham, North Carolina. And I guess it's morning for some of us and afternoon for others. I'm actually broadcasting from Durham, North Carolina. Like I'm sure you've heard, it would be awesome if we were all in Vegas together, but that was not possible this year. And I just want to recognize the AUA staff for being able to pull this together on such short notice and do such a great job with this meeting. I'm joined today by two wonderful friends and co-faculty, Dr. Lawrence Karsh, who is a urologist in Colorado, and in Denver. He will introduce himself a little bit more when he gives his talk in a few minutes. Larry and I have had the honor and pleasure of doing this course for a number of years. Dr. Karsh does a lot of clinical trials in prostate cancer, and we're delighted to have him. We have a new member of our faculty, Dr. Evan Yu. Evan is a professor at the University of Washington out in Seattle. We were talking before this that I'm a huge Big Ten fan, and he's obviously a Pac-10 guy, and it was not good for Ohio State yesterday against a Pac-10 team, but it's early in the season. But anyway, we're delighted to have him. He's going to talk about metastatic castrate-resistant prostate cancer. Before I begin, this course was selected for pre-test and post-test questions. So let's get right into the pre-test questions. And our first pre-test question, and I'm going to read this and you'll have a chance to answer this. According to the 2021 AUA Astro SUO guidelines for advanced prostate cancer, which one of the following statements is not true regarding treatment options for men with newly diagnosed metastatic hormone-sensitive prostate cancer? In addition to androgen deprivation therapy, treatment intensification should be considered with Enzolutamide, Apollutamide, docetaxel, or abiraterone prednisone. B, 6 cycles of docetaxel and ADT is recommended in high or low volume de novo disease based on the final analysis of the chartered clinical trial. C, ADT and first generation anti-androgens such as bicalutamide, flutamide, and Enzolutamide are no longer the standard of care for this disease, but can be considered to prevent T-flare when starting agonist analogs. And D, ADT and abiraterone prednisone demonstrated significant improvement in overall survival and progression-free survival in the interim analysis, while the final analysis of the Latitude clinical trial. So we'd like to ask all the attendees to give us the answer, which one of these is not true. I'm going to wait just a few seconds before we move on to pre-test question number 2. Okay, so pre-test question number 2, not quite as wordy, but I'll read it. Approved therapeutic options for patients with non-metastatic castrate-resistant prostate cancer include all of the following except A, Apollutamide, B, Darolutamide, C, Enzolutamide, D, Olaparib. So which one of these is not used in metastatic or non-metastatic CRPC? And we'll give just a second or a few seconds. Okay, pre-test question number 3. Low volume metastatic M1 newly diagnosed prostate cancer should be treated with androgen deprivation therapy plus an additional novel therapeutic. Which one of these agents is not recommended in this setting? Abiraterone acetate plus low-dose prednisone, B, Apollutamide, C, Enzolutamide, D, docetaxel. Low volume metastatic, which one is not recommended in this setting? Okay. Question number 4. For a man being restaged for management of M0, non-metastatic castrate-resistant prostate cancer, which testing is not supported by randomized controlled trials? PET scan, bone scan, CAT scan, serum testosterone. So which one of these is not supported by the randomized controlled trials that were done for agents approved in this setting? And the final question, what statement is correct regarding multidisciplinary care in prostate cancer? Low-risk patients should be seen by GU medical oncology in most cases. Patients with adverse pathology after radical prostatectomy should always see radiation oncology for adjuvant radiation. C, patients with M0 CRPC can have their Enzolutamide, Apollutamide, Darolutamide prescriptions sent to their local pharmacy. D, patients who are undecided about treatment for localized or advanced prostate cancer are good candidates for multidisciplinary clinic referral. So which one of those is correct? And we will not give you the answers right now. We're going to make you stay for the whole course, and we'll give you the answers when we finish. So at this point, it gives me a great pleasure to introduce Dr. Lawrence Karsh. And as I said at the beginning, Dr. Karsh and I have had the pleasure of working together on this course, and he's a great friend and an outstanding expert in advanced prostate cancer. So I'll turn the podium, if you will, over to Dr. Karsh.
Sorry, got my slides advanced here. I'd like to thank the AUA for inviting us. And again, it's a pleasure to be here with my good friends and colleagues, Dr. Judd Mall and Evan Yu. I would like to thank the AUA for inviting us again to teach this course. I'm an attending urologist and director of research at the Urology Center of Colorado. I co-chair the Advanced Therapeutics Clinic with one of my partners, Dr. David Reagan. And we have 2 multidisciplinary tumor boards every month, one for all GU malignancies, the other for advanced prostate cancer. So these are my disclosures. We're going to start with a case, and we have a 50-year-old male with a history of well-controlled hypertension, diabetes type 1, hyperlipidemia. In June of 2021, he presented with a 2-month history of back pain and 20-pound weight loss. PSA was 544. A year ago, it was 3.7. He had a diffusely firm prostate, and we found Gleason 7, 8, and 9 on the biopsy. The conventional imaging using CT scan and bone scans demonstrated diffuse sclerotic lesions in a 4-millimeter right lung nodule. We do germline testing on all patients with metastatic prostate cancer, and that was done. This is what that lung lesion looked like. And when we magnify it, you can see it here off to the left. We did not biopsy it. We're going to follow it. You know, if it disappears after hormone therapy, then we'll know it might have been a metastatic lesion, but we're following that. Now, this was his bone scan. As you can see, this is a super scan. You can't even see the kidneys secreting the radionuclide. He also had very diffuse lesions in his femurs. And so because of a concern, he had palliative radiation to both femurs. He's a young guy, very active, and we wanted to prevent any fractures. So he was started on the oral anti-antagonist, relugolix, had palliative XRT. So you intensify treatment with Enzolutamide or Apollutamide, abiraterone, prednisone, and prostate irradiation, or C, 6 cycles of docetaxel. D, olaparib or rucaparib, and E, a clinical trial. We're going to come back and answer these questions at the end. Just keep in mind there are actually a few correct answers here. So you answer what you feel is the best answer. So there aren't too many papers that we refer to that are 80 years old. This was the seminal paper by Charles Huggins, and the foundational treatment for advanced prostate cancer is still used today. He was a Nobel Prize winner in 1966, and in the same arena of ADT, Andrew Schally was another Nobel Prize winner in 1977 for discovering LHRH agonists. So this is the continuum of prostate cancer. I'm going to focus on the upper part of this diagram. There are two ways to get to metastatic hormone-sensitive prostate cancer, and that is it can be recurrent after patients have been treated for localized disease with radiation or surgery, or patients who walk in the door with metastatic disease. I think in 2010, there was a statistic of about 4.5% of men walked in the door. There was some data presented the other day by Ken Kernan showing that that's almost double now in 2021. So we're seeing more and more of these patients. But once they progress from metastatic hormone-sensitive prostate cancer, then they are metastatic CRPC. Drs. Mal and you are going to focus on this lower part of this diagram. So are there differences between de novo and patients who have evolved or progressed following primary therapy? There actually is not a huge amount of data out there. There's intrinsically a belief that de novo disease represents a more aggressive biology as opposed to those who evolved. And this was published in 2017. It was a small retrospective study. I wouldn't call it high science, but the observation was that it was at least some data that would suggest that, in fact, people with de novo disease do worse. So these are the AUA guidelines, AUA Astro and SUO. We use these guidelines. They're easy to navigate. You'll notice that they use the terminology metastatic hormone-sensitive prostate cancer. We also use NCCN guidelines, which are very comprehensive. They're a little more difficult to navigate, but they have all of the guidelines that we need. You'll notice they use castration-naive prostate cancer terminology for this disease state. So other terms in the literature are used to just define the same disease state, metastatic castration-sensitive prostate cancer. So you're going to see these things used interchangeably. Metastatic hormone sensitive, metastatic hormone naive, metastatic castration naive, and metastatic non-castrate prostate cancer. These patients all have castrate levels of testosterone with progressive PSA or imaging progression. So let's look at the first guideline statement 13. In patients with metastatic hormone sensitive prostate cancer, regardless of age and family history, clinicians should offer genetic counseling and germline testing. Now, we do this in the reverse order. We do the germline testing first. We now test all patients with metastatic prostate cancer, and we have the discussion about the pros and cons of germline testing and the implications for the family. And then we also use this to screen patients in some of our clinical, to get them into clinical trials. But if they're positive, then we'll send them off to a genetic counselor. They are inundated with all the counseling they have to do. So we reserve that for patients who are positive. Now, this is the NCCN guidelines for germline and somatic testing. They also include high risk, very high risk regional disease in addition to metastatic disease. And you can see here family history, Ashkenazi descent, and the somatic testing. And as I said, we do this for all patients with metastatic disease. Somatic testing also looks for these HRR mutations, but we also look for MSI high or mismatch repair genes, as well as tumor mutational burden. We can have a discussion about, getting when to sequence these, getting them both up front. We do germline testing up front because it informs the family, and we do have treatment options, but they're later on in the disease spectrum. But Dr. Yu is going to talk about this a little bit more. Now, in patients with metastatic hormone-sensitive prostate cancer, clinicians should offer continued ADT in combination with either androgen pathway-directed therapies like ABI, Apollutamide, Enzolutamide, or chemotherapy. They get the strongest recommendation, which is a grade A. And you can read the reasoning for these the evidence when you open up the discussion tab. So these are the approved agents. We have 4. We have docetaxel, ABI, Enzolutamide, and Apollutamide, and the approvals were based on these clinical trials, which I'm going to go through. So let's review the characteristics of the enrolled patients into the CHARTED study, as well as Latitude and Stampede. In CHARTED, we have a volume or burden of disease definition, and you see the definition in terms of visceral mets greater than 4 bone mets with 1 outside the axial skeleton, and the alternative was low volume. There were 2 trials that evaluated ABI in this disease state, Latitude and Stampede, each with different trial designs with similar results. In Latitude, it was a different than volume definition. They combined a pathologic definition with a volume definition to come up with a risk definition. So you had to have 2 of the 3, Gleason 8 or greater, 3 or more bone lesions and or visceral mets. In some ways, this is similar to the high group in CHARTED. Stampede was different. They're newly diagnosed metastatic node positive or high risk disease with 2 features noted there. So Stampede included M0 patients with locally advanced disease with CHARTED and Latitude did not. So is intensified upfront treatment better when it's given earlier? I'm going to show you some evidence to show you that that it is. And the revolution really began in 2015, and this was based on the CHARTED trial. We did use docetaxel. It was approved in the extreme case of metastatic castration-resistant prostate cancer back in 2004, and that was with the SWOG 9916 and TAX 327. There was about a 2-month survival advantage. We didn't get real excited about it because we had patients on ADT that were living longer. But it wasn't until 2015 when the CHARTED data came out and showed that there was using docetaxel and ADT in this high volume group patient improved survival. So patients, there were 790 patients randomized to ADT or ADT plus 6 cycles of docetaxel. So hitting prostate cancer hard early is critical to long-term control. And these were the results, but the overall survival benefit was really seen in the high volume group. You can see this hazard ratio in the low volume group was 1, and so there really wasn't much of an advantage. The Stampede trial did look at just de novo patients only, and they did show some improvement in low volume, but we don't really recommend it for low volume disease. So this continues. Abiraterone was then the next drug used for intensification in 2017. Again, it was first approved in the pre and post-docetaxel space of metastatic CRPC, and there was a survival benefit. And when we look at upfront ABI in the Latitude trial, we had a significant survival benefit, and it also was shown in the Stampede trial. So this is just the trial design, similar to the CHARTED trial. Again, we had our high-risk definition here on the left, but it compared ADT and ABI-PRED to ADT and placebo. The co-primary endpoints were overall survival and radiographic progression-free survival, and you can see some of these secondary endpoints. So clearly, it was a very compelling survival and RPFS benefit, as you see in the hazard ratios, and it obviously informed practice in a very significant way. You can see the significant hazard ratios. And in the final analysis, this was really upheld. We had about a 16.8-month survival advantage in patients that received upfront ADT and ABI-PRED. And the Stampede trial, it was a MAMS or a multi-arm, multi-stage. It did a similar study with ABI and showed a similar overall survival. And their results were a virtual mirror image of what was demonstrated in the Latitude trial. So you see that overall survival advantage. Now, these are some of the well-known adverse events with ABI: fluid retention, hypokalemia, hypertension, and transaminitis. So there really have been no real major new safety signals along the way. Now, this revolution of intensification was validated with Enzymate. This was a study that was done by the Enzolutamide in Australia and New Zealand. This was not, Enzolutamide was not approved based on this study, but they did have a survival advantage that they were shown using Enzolutamide. Again, Enzolutamide was first approved in the metastatic castration-resistant prostate cancer through the Affirm and Prevail trials, both pre and post docetaxel. Enzolutamide also delayed metastases in non-metastatic CRPC through the Prosper trial. This is the Enzymate trial. Again, these are similar designs using Enzolutamide, ADT, but there was a control arm instead of placebo. It was the standard non-steroidal first-generation anti-androgens like bicalutamide, nilutamide, and flutamide at the discretion of the investigator. And patients were stratified into high and low volume, and they were allowed to have docetaxel. Remember, when these trials were designed, the results of the charted were not out yet. So patients were allowed to go in with docetaxel. And you can see that there was a survival advantage. However, when they added concurrent docetaxel in this trial, patients did not have a survival advantage, and especially in the high volume group, but they did have clinically significant progression-free survival. So androgen receptor inhibitors, Apollutamide and Enzolutamide, they were both approved in 2019. They're both next generation AR signaling inhibitors. They work along multiple steps in the AR pathway, block binding in the tumor cell and the cytoplasm, prevents translocation into the nucleus, and inhibits transcription and results in tumor apoptosis. Apollutamide is less likely to cross the blood-brain barrier. They can both do it. It was first approved based on the Spartan trial in 2018 in non-metastatic CRPC, and again, approved for metastatic hormone-sensitive prostate cancer in 2019. Enzolutamide, similar mechanism of action. It was first approved, as I mentioned before, in metastatic CRPC pre and post docetaxel. It was also approved for non-metastatic CRPC in the Prosper trial and approved for in metastatic HSPC in 2019. So let's look at the ARCHES design. Again, similar trial design, substituting Enzolutamide instead of the other agents that we just talked about. Patients were allowed to have prior docetaxel, and it was stratified by high and low volume disease. One of the key differences here is that the primary endpoint was rPFS. Final overall survival analysis is not mature, but it should be read out at the end of this year. So the drug was approved based on this trial. And the primary endpoint was positive. And you can see it's very compelling for rPFS and a significant hazard ratio of 0.39. And in the subgroup analysis, irregardless of whether the patients were on docetaxel or had high or low volume disease, the benefit was seen irrespective of those. And these are some of the adverse events of interest that we see. I'm not going to go through them in a lot of detail, but there are no real new safety signals. Seizure was low, PRES occurred, which are rapidly evolving neurologic symptoms that can be picked up on an MRI. Other diseases can cause that, eclampsia, sepsis, but these weren't post-marketing studies. There was less than a handful of patients. When patients have hypertension or ischemic heart disease, you want to maximize their management for these conditions, like managing their hypertension, diabetes, or dyslipidemia. We are multi-specialty. I'm not shy about including our primary care physicians or internists or even cardiologists. And falls and fractures, consider bone health and bone targeting agents. I'll talk about that in one slide later. But we want to make sure that the patients are not at risk for falls. If they have to get up at night, we ask them to have a commode or a urinal bedside, to use a cane or a walker if they have balance issues, to use good shoes that fit well and not to have loose carpeting or things on the carpet that they can trip over. Now, this was the Titan trial. They got Apollutamide approved. Again, similar trial design, substituting Apollutamide. So it was Apollutamide in ADT or placebo in ADT. There were 1,057 patients included. They also allowed docetaxel, and it was stratified between high and low volume disease. Primary endpoint was dual overall survival and RPFS, and you can see some of these secondary. So in the first interim analysis, it met its endpoint, overall survival. There was a 33 reduction in risk of death with significant hazard ratio. And for the RPFS, again, very significant hazard ratio of 0.48 with a statistically significant p-value and a 52% reduction in the risk of progression. Now, the final analysis, which was for overall survival, which was pre-specified, was just read out this year, and it was upheld. So it reduced the risk of death by 35%, statistically significant hazard ratio. And when we look at some of the safety analyses, there were no new safety signals. Some of the adverse events of interest are skin rash, fall, fracture, and ischemic heart disease. And you can see that when we adjusted in the Titan trial, in the final analysis, patients were on apalutamide twice as long as they were placebo, about 40 months versus 20 months. When you look at the exposure adjusted AEs, the grades of these were actually grades 3s and 4s actually were a little lower. Skin rash is not a real impediment. It's easily managed. I haven't had to stop drug or put patients on IV steroids. In most cases, I use topical creams or dose reduce. And in many cases, the rash disappears. So how do we choose between these upfront agents? Well, with docetaxel, it's short-term. They're on therapy for 4.5 months in addition to their long-term ADT. With AbbVie and Enza, they're long-term therapies. There may be some financial implications with docetaxel. Patients may need time off from work for the adverse effects. The AbbVie and Enza have prescription copays. AbbVie's now generic. Some of the select toxicities for docetaxel: peripheral neuropathy, hair loss, pancytopenia, as well as nail abnormalities. So in AbbVie, there can be liver enzyme issues as well as electrolyte issues. And so they need more frequent monitoring for this. And as far as Apollutamide and Enzolutamide, they do cross the blood-brain barrier and cause some CNS and cognitive disorders as well as falls, but they are very manageable and they are not extremely high. Now with docetaxel and AbbVie, you need prednisone. There are very low doses that we use, and they're not steroids are not necessary with Enza or APA. Docetaxel was high volume only. AbbVie, Enza, and APA were high or low volume patients, and we described the high and low volume characteristics of patients in some previous slides. So why not combine chemotherapy with these doublet treatments? Well, you saw in the Enzymate trial that there was no benefit for overall survival, but they did show it with the low volume patients. But we need dedicated trials to show the advantage, and we do have some ongoing. Darolutamide, piece 1 was reported out recently, AbbVie and docetaxel. There was no real significant difference in RPFS, but there was a delay in castration resistance with the combination. We don't have overall survival data yet. Now, this is the Arison's trial, which is ongoing, and it involves docetaxel and ADT and darolutamide versus ADT, docetaxel, and placebo. There's about 1,300 patients. They are started on their docetaxel and darolutamide simultaneously. The primary endpoint is overall survival, and we do expect to see the data. It may even come out earlier than August of 2022. Now, in select patients with hormone-sensitive prostate cancers, Guideline 16 with low-volume metastatic disease, clinicians may offer radiotherapy to prostate in combination with ADT. The most recent NCCN guidelines also recommends intensifying treatment with compounds such as APA, Enza, or ABI. And so this is recommended for low-volume disease to irradiate the prostate. And this is the data from the Stampede trial that provides that level 1 evidence. You can see in the low volume patients, there was a survival advantage when you combined radiotherapy with ADT. So what's on the horizon? Well, P13, P10 AKT is a key and frequently dysregulated pathway in cancer. And it is common, it's a common oncogenic pathway that converges to activate AKT. And AKT is a key driver of resistance to multiple therapies, including hormonal therapies and chemotherapy. And there is a genetic marker that we can use called P10 to screen these patients who might respond to something like capivasertib, which is an AKT inhibitor. And this is the Capitello trial. We estimate there are going to be about 25 to 30% of patients that have with metastatic prostate cancer that have the P10 deficiency. So you can see that 5,500 men are going to have to be screened in order to get about 1,000 patients. So if they have P10 loss and it's picked up by immunohistochemical screening with their tissue, if they have the P10 loss, then they will be screened into the study. And then if they pass all the screening, then they are randomized to CAPI plus ABT, ADT plus ABI, or placebo plus ADT and ABI. And the primary endpoint is rPFS. You can see some of the key secondary endpoints. Overall survival is included. Now, this is another phase 3 trial in metastatic hormone-sensitive prostate cancer, substituting Helizoprib and Enzolutamide, so that these patients are going to have to be pre-screened for HRR mutations. And if they have the HRR mutations, then they can be screened for the trial. And they're going to be randomized to Tala and Enzolutamide and ADT versus placebo and Enzolutamide. I'll just say one thing about the mechanism of action of Parp inhibitors, but Dr. Yu is going to explain that better. But, you know, the DNA code is damaged 12,000 times per day per cell. And due to exogenous and exogenous factors such as UV radiation, ionizing radiation, and genotoxic chemicals, DNA is under constant risk of damage. So that, you know, there are multiple repair mechanisms are needed, and they're collectively referred to as DNA damage response. One of those responses repairs pathways is homologous recombination repair, and they repair double-stranded breaks. So the key mechanism, one of the key mechanisms of action of Parp inhibitors are that they trap Parp on the DNA where the complex then presents a physical obstacle to the DNA replication machinery, resulting in double-stranded breaks. So in HRR deficient cancer cells, Parp inhibitors can cause replication fork collapse and finally cell death and apoptosis. So the primary endpoint, rPFS, secondary endpoints in this trial, OS. So that's the rationale for using a Parp inhibitor with a next generation hormone therapy. Amplitude, similar trial design using the Parp inhibitor niraparib and abiraterone, as well as ADT. There's going to be 788 patients. They have to have the HRR gene mutations in order to qualify for the study. The primary endpoint is rPFS. Overall survival is one of the secondary endpoints. These are some of the ongoing phase 3 trials. You can see Aranote looking at ADT plus or minus Enzolutamide. and Keynote 991 was ADT and Enzolutamide plus or minus pembrolizumab. So don't forget bone health. This is something that any patient that we start on ADT, we start them on vitamin D and calcium. Vitamin D, our standard dose is 2,000 units. Calcium, you have to be careful not to use too much. We have patients take a 500 milligram calcium tablet, especially if they're going to be on an anti-resorptive. But we recommend exercise, especially resistance exercising, cardiovascular exercising, smoke cessation, alcohol, reduce their alcohol consumption. Any patient that started on ADT gets a Dexafrax, as well as a dental consult if they're going to start an anti-resorptive, such as denosumab and bisphosphonates. If they have osteoporosis, they get low-dose denosumab or bisphosphonate. The high dose of these two drugs are reserved for metastatic castration-resistant prostate cancer for prevention of skeletal-related events. Now, there was a paper in 2014 by the CALGB group that had a publication on using zoledronic acid high dose in castration-sensitive prostate cancer with bone mets. But their conclusion was that in this disease state, early treatment with zoledronic was not associated with lower risk for SREs. And you can see that there is no difference. The lines are just overlaid. So we don't use high dose osteoclast targeted agents for metastatic hormone sensitive prostate cancer. We will do DEXA scans and treat these patients if they have bone loss with low dose options. Now, this is a real world pattern of adoption of intensification. And it looks, unfortunately, it looks like we're not following guidelines out there. This is presented by Scott Tagawa at ESMO in 2020, which shows that only 60% in the VA of patients are received, that 60% of patients receive ADT only, and another 17% receive ADT and a first generation anti-androgen. So that only a quarter of the patients are receiving the recommended therapies for intensification. Now this goes up to 2018. APA and Enzo were approved in 2019. But again, this is a community oncology setting. Same thing. Only 44% of the patients received the recommended intensification therapies. And this is among oncologists, and it went out to 2019. This is Optum health insurance claims going to 2019. Only a small fraction of the patients were intensified for treatment. You can see that 56%, even though we've known about intensification since 2014 and 2015, 56% of patients are in ADT alone. And when it comes to ADT and first generation, 14%. So 3/4 of these patients are receiving treatment that's not recommended by the guidelines. And when we look at Medicare SEER data, we see that 83.5% of patients are getting ADT plus are getting ADT and possibly a first generation androgen. So let's remind ourselves of the NCCN guidelines, same as the AUA, where these are the preferred treatments for therapy to intensify ADT in castration sensitive, metastatic castration sensitive prostate cancer. So why are we not intensifying ADT per the AUA, ASTRO, and NCCN guidelines? I don't have a good answer for that. Is it a knowledge gap? Are we not getting the message across? So we don't have answers to this, but we really need to do a better job of treating these patients according to guidelines. And so these are future directions. I've gone through some of these trials for metastatic hormone sensitive prostate cancer. We're moving everything up earlier, and there are trials in active surveillance as well as localized disease with radiation and biochemical recurrence. I showed you some of these triplet intensification therapies. And as we go forward, we're still trying to personalize medicine with next generation sequencing and predictive markers. We're going to have next generation imaging. The PSMA imaging will be approved this year, targeted radioligands like lutetium combinations, which I talked about, and checkpoint inhibitors. So in summary, monotherapy is no longer the standard of care. Treatment intensification strategies are stratified by high or low volume. Docetaxel is for high volume disease, ABI, APA, and Enza for low volume or high volume disease. Triplet therapy, which includes docetaxel, PARP inhibitors, AKT inhibitors, and checkpoints may be beneficial, but further efficacy trials are needed or underway. Consider radiation therapy to prostate and intensification in low volume patients, and genetic testing, somatic and germline, is recommended for all patients with metastatic prostate cancer. So let's get back to our question. We have a patient who's diagnosed with high volume metastatic hormone sensitive prostate cancer who has received an antagonist. You intensify treatment with A, Enzolutamide or Apollutamide, B, ABI, prednisone and prostate XBRT, 6 cycles of docetaxel, olaparib or caparib, or a clinical trial. Let me just go back here, sorry. Do we have our answers posted?
Larry, this is Judd. Well, first off, fantastic job. Covered a lot of ground in a very, efficient period of time. And we do have some answers coming in, and it looks like the most popular answer is C. So 71% of the audience picked C, 14% picked A, Enzolutamide or Apollutamide, and 14% said clinical trials. So again, 6 cycles of docetaxel was 71%. You want to comment on, Larry, how you manage this patient?
Yeah, so I think there are some correct answers. A is correct. C, 6 cycles of docetaxel or a clinical trial. ABI and prednisone can be used for high or low volume disease, but prostate XBRT is only for low volume disease, so that's an incorrect answer. Olaparib or caparib, Dr. Yu is going to talk about this. It's indicated only in metastatic castration-resistant prostate cancer, and I'll give you the nuanced differences. This patient got 6 cycles of docetaxel. We're also looking at that lung lesion. Our medical oncologist likes to treat visceral mets with docetaxel, but because 6 cycles of docetaxel was approved in the Amplitude trial, the patient is on his 3rd cycle, and he has a germline HRR mutation, the CHEK2. He's going to be enrolled in the Amplitude trial, which is niraparib and ABI and ADT versus ADT, ABI and ADT. So that's what we chose for this patient. So thank you very much, and we'll move on.
Thanks so much, Larry. Before you go on mute, I want to just, I think we have a minute. The questions coming in on the chat box with regard to COVID. The COVID pandemic has been going on for a year and a half, and there's delay in diagnosis in some cases. And if a patient has documented significant delay in diagnosis where you believe that the delay in diagnosis is what caused the metastatic prostate cancer, do you really need to do genetic testing?
I still do genetic testing on metastatic, on all metastatic patients, because it informs us. If it's germline, it actually will inform the family, and it will inform clinical trials. But we now have therapies in metastatic CRPC, that are approved. And I think that it's important to get both the germline and somatic, no matter when they're diagnosed with metastatic disease. But we can have a discussion on when do you get the germline, when do you do somatic, do you do them simultaneously, or do you do germline first and then somatic second? And that's basically what we do, but we're moving somatic up earlier.
Sounds good. The issue with the, COVID is, of course, we can blame COVID on everything, I guess, but do you believe that the COVID pandemic and issues, with healthcare providers and pharmaceutical colleagues not being able to interact as much may be somewhat responsible for us as a specialty or specialties not following the guidelines. I mean, it is kind of sad that we still have 60% of the time men with metastatic prostate cancer may not be getting proper therapy. I don't know, maybe, and Evan wants to comment on that as well. Just a brief discussion of that at this moment in time.
Well, Judd, I think that with COVID, it has affected things, but COVID, we had these guidelines before COVID. So I think that it has had an impact, but I'm hoping that going forward, that we're going to see an increase in the use of intensification treatments.
Yeah, I'll comment further on that. I'll just say that I totally agree. COVID has certainly had an effect, but the honest truth is that it goes a lot larger than that. I think that, these guidelines are important, and it's endeavors like this and others where, we need to get the word out. And as time goes on, the number of patients that receive treatment intensification will increase, and it should increase appropriately so. But I think it goes beyond COVID, and we need to continue to get the word out that these are significant benefits. These are not median 2, 3, 4, 5 month benefits like we see in, to be honest, in a lot of cancer trials. These are like a 1.5 to 2 year type of benefits. So this is something we have to do. We have to get the word out, and our patients need these treatments.
I don't know if it's this way as much in Colorado or in the state of Washington, but I can tell you in North Carolina, there's a maldistribution of healthcare workers in regard to, medical oncology and urology. And in our state, some of our pockets with the highest risk of prostate cancer and the worst prostate cancer are counties that have no medical oncology and no urology, and especially no GU medical oncology. So different. I think I'm in a state where there's also a maldistribution of resources that may be playing into it. And I would love to see data that, that's further substratified by socioeconomic status and getting those appropriate therapies. I don't know on your slides, Larry, I didn't take notice if they were stratified by socioeconomics or health insurance status.
No, they weren't. But I think there was one slide where socioeconomic status was not a big issue. But I think we need to delve into that further. And I think they're going to take a deeper dive. Scott Tagawa and Dan George are really heading that, these real world surveys. So we have to delve into it deeper and figure out what it is that we need to do on our end. We're trying by putting on these courses, but I think docs should really follow guidelines. That's very important.
Well, and the data is pretty strong on a survival benefit for these agents. Well, we'll move on. I have a fairly brief talk. Dr. Karsh and Dr. Yu have had the heavy lifting on this course because there's really a lot of new stuff. And again, I want to thank Dr. Karsh, particularly covering some of the new trials that are, being done right now in, hormone-sensitive metastatic prostate cancer. I'm going to give a brief overview of non-metastatic castrate-resistant prostate cancer. These are my disclosures over the last 3 years. I'm going to go through. So, the first question with regard to non-metastatic or M0 CRPC, why should we even care? Some people would say, oh, it's a kind of a made up disease stage, if you will, and there's not much to do for it. Well, we now have 3 non-steroidal second or third generation anti-androgens that are FDA approved since February of 2018. And these patients are in urology practices for the most part, and not yet in GU medical oncology practices. So I think we as urologists are on the front line to identify these patients. Management of advanced prostate cancer with hormonal therapy has been traditionally managed by urologists, and this should continue. And again, even if you do not want to manage CRPC, 2 of the 3 agents are also now approved for new M1 prostate cancer. And Dr. Karsh covered that beautifully with regard to enzalutamide and apalutamide, and updates on the Titan trial and so forth. So again, even if you do not manage castrate-resistant prostate cancer and are going to refer those patients to experts like Dr. Yu, again, apalutamide and enzolutamide are now also approved for a newly diagnosed M1 prostate cancer, and there's definitely room for improvement, as you heard Dr. Karsh mention, 50 to 60% of these metastatic cases are not getting one of these therapies, and so there's definitely room for improvement. The oral agents are safe and extend metastasis-free survival by an average of 2 years and increase overall survival. So again, we're talking about enzolutamide, apalutamide, and darolutamide. All have been proven to extend metastasis and overall survival. 2 years, on average, 2 years without demonstrating metastasis, I would argue, is clinically meaningful. It's more than just statistically significant, it's clinically meaningful. And 2 years more without having to necessarily switch doctors is important too. As a urologist, you could use one of these oral agents, extend metastasis-free survival, and in general, keep these patients fairly stable and doing well without having to necessarily make a referral. And for the majority of men, the 2 years or more is quality life, not just life, because the drugs are well tolerated. And using these 3 oral agents is straightforward with proper education. So non-metastatic CRPC, what are the key learning points? It's a rising PSA on continuous androgen deprivation therapy with a castrate serum testosterone level and no metastasis on standard imaging. The clinical trials utilized standard bone scans and CAT scans and did not utilize PET scans. There are 3 FDA-approved oral agents, apalutamide, enzolutamide, and darolutamide, and all have now been shown to improve survival, and that was from last year's ASCO meeting. All of them are potent. I consider them 3rd-generation oral nonsteroidal anti-androgens. Some people consider them 2nd-generation, but anyway, they're generally safe and well tolerated. The key side effects are fatigue, falls, fractures, rare seizures, rash, and chemical hypothyroidism. And Dr. Karsh covered some of those side effects very well when he talked in his last talk, and no special monitoring during use. Just a case just to cement the concept, 73-year-old retired grocery chain executive in robust overall health, presented about 5 years ago. He had moderate volume, Gleason 4 + 3 = 7, and a PSA of 13. He was seen at the Duke Multidisciplinary Clinic, where at the time of his diagnosis, he was seen by a surgeon, a radiation oncologist, and a medical oncologist. He elected radical prostatectomy after full counseling by all 3 specialists. His post-op surgical pathology, unfortunately, was upgraded and upstaged to T3B and Gleason 9. He received adjuvant EBRT. And again, this was a couple years ago before the new guidelines looking at adjuvant versus salvage. But he did receive adjuvant radiation therapy and 6 months of ADT post-operatively at the time when he regained his continence. Then his PSA began to rise 3 years ago. At a PSA level of 5, he restarted ADT. His PSA declined to a nadir of 0.5, but then about 7 months after restarting the ADT. But currently he has a PSA of 2.8, a castrate serum testosterone level. Restaging bone scan and CT were negative for metastasis. And not on this slide, but his PSA doubling time was about 9 months. So the key message here, this gentleman clearly has textbook non-metastatic CRPC, and his options would be to treat him with one of these agents, or I suppose not treat him. but not management of non-metastatic CRPC is based on having a castrate testosterone level less than 50, no tumors seen on standard imaging, nuclear medicine bone scanner CT, and the 3 clinical trials where these drugs were approved all had patients had a PSA doubling time of less than 10 months, indicating what they considered a high risk non-metastatic CRPC condition. In other words, these men were destined to get metastasis in a fairly short period of time if they were not treated. And so again, the 3 approved agents are Apollutamide based on the Spartan trial, Enzolutamide based on the Prosper trial, and Darolutamide based on the Aramis trial. You see here the dates when these drugs were approved. Apollutamide was first out of the gate in February of 2018. In fact, it was FDA approved on Valentine's Day 2018. Certainly a nice present for Janssen and Johnson & Johnson, who got first approval. Then Enzolutamide in July of 2018, and that is a Pfizer and Medivation drug. And then Darolutamide in July of 2019, and that is a Bayer Oncology product. Again, just showing the title slide. All 3 of these pivotal clinical trials were published in the New England Journal of Medicine. Here you see for Apollutamide, here you see for Enzolutamide, and we certainly need to give credit where credit's due to all the clinical researchers, the clinical trialists who participate in these trials. And this is the Aramis trial. When we compare these 3 studies, Prosper, Spartan, and Aramis, again, they're very similar. All of them were traditional ADT plus either Enza, APA, or Daro versus placebo. All of these studies were fairly large, anywhere from 12 to 1,500 patients. All studies used a 2-to-1 randomization, and they were generally stratified by a PSA doubling time less than or equal to or greater than 6 months. PSA doubling time was less than or equal to 10 months in all 3 trials, and all 3 trials had a baseline PSA more than 2.0 when they were eligible to start therapy. And I think that's another key teaching point, is that in general, I follow these trials, and if I have a patient who I'm considering using one of these agents, I tend to follow the guidelines. And when the PSA is greater than 2 and the castrate testosterone they have a castrate testosterone level and they fit the criteria, they become eligible for one of these 3 agents. Patients with a history of seizure were excluded from Prosper and Spartan, but were allowed in Darolutamide. Again, as Dr. Karsh alluded to, the Darolutamide does not really cross the blood-brain barrier and is associated with a lower rate of seizures and falls. With regard to cardiovascular disease event exclusion, the Prosper trial with Enzolutamide did exclude significant cardiovascular disease, as did Aramis, but the Spartan trial with Apollutamide did not exclude patients with cardiovascular disease. And the primary endpoint was all metastasis-free survival, although they've now also been proven for overall survival. So both of the primary and secondary endpoints have been met. All of them pretty much extended the metastasis-free survival by about 2 years. And all of them now have a statistically significant survival advantage compared to placebo. They all are well tolerated, but they all can have side effects. And I'm not going to go into great detail on this slide. However, fatigue, hypertension, rash with Apollutamide, falls, fractures, mental impairment disorders can be present. And I would say a clinician, a urologist needs to be familiar with these side effects, know how to manage them. And even if a urologist is not comfortable prescribing all 3, pick one that you want to get comfortable with and treat the patient, in my opinion, or refer to medical oncology, but not being familiar is it's not that difficult. These are fairly straightforward for a board certified urologist. Now, the Spartan trial was updated at ASCO 2000, as were all of them since then. And this was the third analysis with a median follow-up of 52 months. Median overall survival was 73.9 with Apollutamide and 59.9 with placebo. That was a significant hazard ratio and a significant p-value, and it did meet the pre-specified target for statistical significance. That translates into about a 21% relative risk reduction of death from prostate cancer, and that was presented by Eric Small from UCSF. Prosper final survival or updated survival analysis showed a 27% decrease in the risk of death at a median follow-up of about 4 years. The median overall survival was 67 months for Enzolutamide and 56 months for placebo. Enzolutamide treated participants longer time to first use of subsequent anti-neoplastic therapy than their placebo-treated counterpoints at a median of 66 versus 19 months, and that was presented by Cora Sternberg. And then finally, darolutamide or Aramis update at ASCO 2020, 31% reduction in the risk of death at a median follow-up of 29 months. 3-year overall survival rate was 83 versus 77%. And darolutamide was associated with significant delays in the time to pain progression, first cytotoxic chemotherapy, and first symptomatic skeletal event. And that was presented by Karim Fizazi from France. The summary at that point, and again, at that ASCO in 2020, they had all 3 of these trials reported on overall survival. And the discussant was Tom Beer from in Portland. And his comment, he made it clear that in castrate-resistant prostate cancer, early intensification of hormonal therapy results in an overall survival advantage. He added that meaningful differences in the efficacy between these 3 studies are not apparent. And although the median overall survival estimates and hazard ratios look a bit better in the trials with longer follow-up, these studies are not necessarily fully mature for overall survival, and it may change with additional follow-up. So I think the key message is, how do we identify M0 CRPC in our practices? I would say if you see, and this is for all your staff, if you're in a urology practice, you need to train all the staff from your registered nurses to your CMAs to anybody to at least recognize if you have a patient who's on leuprolide therapy or degarelix or hormone therapy without metastatic disease and their PSAs rising, let your staff know that they need to let someone in the practice know. So identifying these patients is important. Some people say this stage is going to go away in the PET scan era, and that may be true, or it's certainly the stage will shrink because as more accurate PET scanning comes into our practices, the tendency will be to do a PSMA PET or do an Axeman scan and find metastatic disease. And then you would treat those patients just like Dr. Karsh talked about in his talk, which you could use at least 2 of the 3 agents, whether they had metastasis or not. How to decide between apalutamide and enzalutamide and darolutamide, because how do you do that? They're all 3 generally well tolerated. Urologists do need to be aware of some of the unique side effects. All 3 of these agents are expensive. We're not going to hide that fact that we're not talking about the days when you could write a flutamide prescription on a prescription pad and send the patient to your local pharmacy. These drugs all require specialty pharmacy support and prior authorization. Medical oncology practices are well equipped to do this. One of the challenges on some smaller urology offices perhaps is not having the expertise or the bandwidth to deal with specialty pharmacy. Medicare patients generally have more out-of-pocket costs than private plan patients because of the way Medicare is structured with oral medications. All of these agents delay metastasis-free survival for about 2 years on average, and the overall survival benefit is now proven for all 3. So to the final learning points on this section, non-metastatic CRPC is a rising PSA on continuous androgen deprivation therapy with a castrate T level and no metastasis on standard imaging. 3 FDA-approved agents, APA, Enza, and Darolutamide, all are potent second or third generation oral non-steroidal anti-androgens, which are generally safe and well tolerated. We discussed the key side effects and that urologists in practice need to be aware of these side effects, know what to look for, how to manage them. But again, it's definitely doable. No special monitoring is required of when you're using these agents. So summary pearls, 3 third-generation oral anti-androgens, all improve metastasis-free and overall survival, all can cause fatigue, falls, bone fracture, hypertension. Apollutamide can cause rash, and there's a slight risk of hypothyroidism. Enzolutamide, perhaps more fatigue and seizures, although that's controversial. And darolutamide, less penetration of the blood-brain barrier, potentially less fatigue, falls, and fractures. We need to avoid Enza and APA with this patient with a seizure disorder. So with that, I will stop and turn the podium over to Dr. Yu, unless I know, Evan, you've been monitoring the chat box during my talk. So if there's any questions that you feel we should address right now, we can do that.
Thanks so much, Judd. I think there's one question, but I think we can address that kind of at the end about the insurance companies and the cost of the oral, androgen pathway inhibitors. I think that's a good discussion for the very end, and how to deal with those sorts of situations. So why don't I share my screen, and I'll go ahead and get ready. Here we go. All right. So I'm going to talk about metastatic castration-resistant prostate cancer. Here are my disclosures for the last year. And of course, I'll be discussing some non-regulatory approved agents in this presentation. So as far as discussion topics go, I'm going to talk a bit about DNA repair alterations, Parp inhibitors, DNA repair deficiency, and also the use of PD-1 inhibition immunotherapy with mismatch repair deficient, microsatellite high, and tumor mutational burden high prostate cancers. Now, again, the point of this course is to really focus on the latest and greatest in the last year or so. There have been some updates, but these are things that I think are very, very important for the field. They may not have been presented just come out in the last year, just a little bit beyond the last year, but I think they're important to review. And then the rest of the talk will be focused on things that have come out in the last year or that will be coming out. That includes some data on Apollutamide, which is an AKT inhibitor, and also the ACES trial, which is combination therapy for metastatic castration-resistant prostate cancer, abiraterone and apalutamide, and of course, the radioligand therapies, the PSMA-targeted theranostics like lutetium, PSMA-617. I'll talk both about the VISION trial that was presented at ASCO this year in the plenary session and the Therapy trial that was presented at the General Urinary Cancer Symposium just this year. And then I want to think a little bit about what might be coming ahead in the future with the bispecific antibodies. So with that being said and done, I wanted to start off with the case. And this case is a 72-year-old gentleman who presents with urinary obstructive symptoms. He's got no significant past medical history or family history. His PSA was 32 and his prostate exam was diffusely indurated. He undergoes staging scans. His chest, abdomen, pelvic CT scan reveals multiple lung and liver metastases, bone scan with widespread osseous metastases. He started on androgen deprivation therapy, and since he clearly has high volume disease, the provider and the patient preferred 6 cycles of docetaxel. There actually was a significant discussion about the androgen pathway inhibitors versus docetaxel, but one thing that some patients like is the fact that they like just being done with it. 6 cycles of docetaxel, 6 and done, rather than continuing on oral androgen pathway inhibitors. His PSA natered to 2.4 after 9 months before his PSA started to rise consecutively. He then received abiraterone acetate with prednisone with an initial decline, but 9 months into therapy, his PSA began to rise and it began to double monthly. still asymptomatic, and you start discussing options with the patient, like switching to Enzolutamide, back-to-back, AR targeted therapy switch, or chemotherapy as a potential option as well. But my question to this group is to think about is, besides restaging imaging, which of course you're going to get, and you're going to check some labs as well, what other testing would you recommend? And when would you have ordered these tests? And Dr. Karsh addressed some of these issues and was talking about them earlier: germline testing, somatic next generation sequencing, genetic counseling. So some of these issues were brought up, but they're incredibly important. So, as they tell us in medical school, the volume of stuff to learn is huge, but if it's really important, you're going to hear it again and again and again. And that's what we're doing here is talking about this issue again and again and again here. And so here are the guideline statements. And Dr. Karsh showed you guideline statement 13, which is in patients with metastatic hormone sensitive prostate cancer, regardless of age, regardless of family history, clinicians should offer genetic counseling and germline testing. This is expert opinion. And the reasons are pretty straightforward, twofold. One is certainly it might affect treatment options down the road for the patient, in terms of Parp inhibition or PD-1 inhibition. But perhaps even more important are the downstream family implications in terms of cascade testing, identifying patients' families who might be carriers of these high-risk genetic predispositions for cancers, not just prostate cancer, maybe breast, ovarian cancer, and doing the appropriate intervening early screening tests, finding cancers early, and potentially saving a lot of lives down the road. And so that's why this is very, very important to do this germline testing. Now, in terms of metastatic castration-resistant prostate cancer, I think the timing is a little bit more questionable. There's no clear right or wrong answer. Some people will test as soon as you have metastatic disease. Others might wait until they have metastatic castration-resistant prostate cancer. Others might do it immediately upon that diagnosis. Some might wait a little bit later down the road to the time point when maybe treatments with Parp inhibitors or immunotherapy become standard of care on label. So this is guideline statement 26. In patients with metastatic castration-resistant prostate cancer, clinicians should offer germline somatic tumor testing to identify DNA repair deficiency mutations and microsatellite instability status that might inform prognosis and counseling regarding family risk, as well as potential targeted therapies, expert opinion. And so, again, this is what I'm talking about here is this: the germline testing, I think, is a hands down metastatic disease, whether you have castration sensitive or resistant disease. The somatic testing, more for castration resistant prostate cancer, because that's more for selection of treatment options and for informing prognosis. And that's where those treatment options kind of fall in the metastatic castration-resistant prostate cancer disease state, at least with the Parp inhibitors and with immunotherapy. And we'll talk more about that in detail. So here's the DNA repair gene alterations for homologous recombination deficiency. And actually, they included some of the mismatch repair genes. But that being said, then the graphic on the left is for patients with metastatic castration-resistant prostate cancer. And this was the data from the Stand Up to Cancer Dream Team, the international dream team that grouped together to do metastatic biopsies of patients with metastatic castration-resistant prostate cancer. And they did sequencing across the board and surprisingly identified that 23% of the patients had some sort of mutation or alteration in these DNA repair genes. So with that being said and done, about half were germline and about half were somatic, but they did seem to be more of these when they tested in patients with later stage disease. And probably those were more somatic alterations, since germline is inherited in every single cell and, a presence at, at birth. Now, on the right graphic, we have the data from the New England Journal Colin Pritchard paper, which looks at metastatic prostate cancer. And this includes both castration-resistant and castration-sensitive patients, and is focused on germline inherited mutations. And as you can see here, about 12% of patients had inherited some sort of germline alteration in one of 16 DNA damage repair genes. And interestingly, age and family history did not affect mutation frequency, and that's why that term, that phrase appears in the guideline statement 13, as both Dr. Karsh and I mentioned. So here's the implications for it. Well, here's the randomized control phase 3 trial with Olaparib versus AR targeted therapy switch. So if you were on abiraterone, switch to enzalutamide. If you were on enzalutamide, switch to abiraterone. And they broke it down into 2 cohorts. They had patients with metastatic castration-resistant prostate cancer. They did the sequencing testing. If you had a BRCA1, 2, or ATM mutation, you were in cohort A. If you had one of the other homologous recombination repair gene mutations, you were in cohort B. Both cohorts would then randomize to either olaparib 300 BID or investigator choice, essentially switch, and continue to radiographic progression. And there was optional switch then at the point of progression to olaparib or crossover. Okay. And the primary objective was radiographic progression-free survival, but there are multiple key other secondary objectives. And here's the primary endpoint data, and this is for cohort A, which is how they designed the study pre-specified for the BRCA1, 2, or ATM cohort. You can see a very statistically significant improvement in radiographic progression-free survival there with a hazard ratio of 0.34. And here's the overall survival data from the final analysis, also significant for cohort A with a hazard ratio for death of 0.69. So a 31% reduction in the risk of death for those patients with a BRCA1, 2, or ATM mutation. Here's the safety data, and there are things that one might expect with a Parp inhibitor. So we know that Parp inhibitors can cause myelosuppression, so anemia appears high there, can also cause some subtle GI symptoms like nausea or change in taste. And that's what you can see here as well, decreased appetite. These are common nuisances that patients report. They're not huge or dramatic high-grade toxicities, but they can be things that are challenging for patients going through and that can affect their quality of life. So here's the Triton-2 data. This is with rucaparib, and this is another Parp inhibitor, and this was an open-label phase 2 study that led to its accelerated approval. So with olaparib, it was a full approval. This was an accelerated approval, olaparib, because there was a progression-free survival and an overall survival benefit. This primary endpoint, however, with rucaparib 600 milligrams BID for those who had the homologous recombination repair gene alterations, the primary endpoint here was objective response rate. And you can see here the objective response rate was 33% for investigator evaluable population, but for the IR evaluable population was 27%, and confirmed PSA response rate was 63%. And if you look on the right there, you can see the breakdown, and they have breakdown on waterfall plots, and you can see it's broken down based on whether they're BRCA1 or 2, or whether they're germline and somatic. And so you can see there that BRCA2 is still the predominant alteration that we see more of, fewer BRCA1 alterations. And this fits with what we know in the literature, that if you look at the homologous recombination repair gene alterations, BRCA2 is the most common and probably the most important driver of response to Parp inhibitors. The safety data, not very dissimilar from what I just showed you with olaparib there. You can see there's some asthenia and fatigue, some GI side effects with nausea, and of course the myelosuppression with anemia as well, decreased appetite, some constipation, of course some decreased platelets. These are all some things that you can expect to see when you're treating patients with Parp inhibitors. So here are the FDA approvals. On May 15th, 2020, based on the data from Triton-2 study, the FDA first granted accelerated approval to rucaparib for the treatment of patients with deleterious BRCA1 or 2, whether it's germline or somatic, associated metastatic castration-resistant prostate cancer who have been treated with an androgen receptor-directed therapy and a taxane-based chemotherapy. And so Foundation 1 liquid CDX was a companion diagnostic for rucaparib, and that came later in August. The things to point out here that are important is this really follows the study design well. I didn't emphasize that earlier, but these patients were patients who had received AR-targeted therapy with abiraterone, Enzolutamide, et cetera, and taxane-based chemotherapy. So this was really a post-taxane situation. Now with olaparib, they, on May 19th, just 4 days later, were granted full approval for those with pathogenic, germline, or somatic homologous recombination repair gene mutated metastatic castration-resistant prostate cancer who progressed following prior treatment with enzalutamide or abiraterone. The list of genes are listed there, the companion diagnostic being the BRCA analysis CDX and Foundation 1 CDX. The important distinction here to recognize here is the fact that these patients can be in a pre-chemotherapy setting. Whereas rucaparib, it is logistically in the post-chemotherapy setting. And with rucaparib, they selected out the fact that it was really BRCA 1, 2. A little bit more precision medicine there. With olaparib, we see that the benefits are really driven by cohort A, which are the BRCA 1, 2, or ATM mutated patients. But with fine dissection, they grouped everything together and there was a benefit overall. But with fine dissection, it really still is driven by that cohort A. But that being said and done, they have a broader approval. Okay, so precision medicine is important to recognize. And some have brought up the question about how precise is this? I think that there are patients with some of these DNA repair gene alterations that are less common that can respond really well to PARP inhibitors. For instance, PALB2, maybe the FANK-A genes, et cetera. The challenge is that these are really rare mutations and there's just not enough data out there. So it's understandable that a label is rather broad because, they want to be able to capture those patients as well. Now I'm going to move on to the PD-1 inhibitors. For instance, pembrolizumab has a broad approval with patients with solid tumors and that have microsatellite unstable, hypermutated, or mismatch repair altered solid tumors, including prostate cancer. So a little bit of that data. We have a propaganda here, a little bit from the University of Washington Rapid Tumor Autopsy Series. We have the largest rapid tumor autopsy program in the country where our very grateful patients are dedicated to helping us move the needle forward in prostate cancer, have donated their bodies to us within 4 hours of passing away, and that we can use their tissues to do a lot of different studies. We do derive patient-derived xenograft models. We characterize those models. And with that, we looked at mismatch repair alterations and microsatellite instability. And in this series, we found that 12% of patients actually had mismatch repair alterations that were generally MSH2 or MSH6, and they were hypermutated. Now, that being said and done, when you look at the Stand Up to Cancer series, which I showed you before, and you do metastatic biopsies, it's closer to 3%. And that's not that surprising because these patients are actually still alive, whereas our rapid tumor autopsy series, it just shows that maybe when you get closer to death, these sorts of alterations kick in more. And so these might be later events, somatic events that are occurring. So the truth is somewhere in the middle is probably for the metastatic castration-resistant prostate cancer population, somewhere between this 3% and 12%. I always kind of estimate maybe in the 5% range. But 5% is still worth considering and testing for. And this is the reason why. Pembrolizumab has a tissue site agnostic approval. And it's for patients initially in May 2017, the US FDA granted accelerated approval to pembrolizumab for adult and pediatric patients with unresectable or metastatic microsatellite instability high or mismatch repair deficient solid tumors that have progressed following patient treatment and who have no satisfactory alternative treatment options. Then in June 2020, the FDA granted further accelerated approval to pembrolizumab for those who had tumor mutational burden high, so greater than 10 mutations per megabase solid tumors, as determined by an FDA-approved test that have progressed following prior treatment and have no satisfactory alternative treatment options. This makes a lot of sense to me because if you think about how this should happen, you carry biallelic alteration, loss of heterozygosity in a mismatch repair gene, MSH2, MLH6, or MSH6, MLH1. You have one of those that leads to microsatellite instability, and the result is you get hypermutation across the board. So it totally makes sense that you should have this approval for hypermutation because that's really what does its effect. It's kind of like looking at a DNA mutation, but then saying what really takes effect is not the DNA. It's the DNA has to get transcribed to mRNA, which then has to get translated to protein. So looking at this hypermutation, that's really what's causing these patients to have mutations across the board, abnormal proteins that your immune system can recognize. Your T cells can infiltrate into the tumor. And that's why PD-1 inhibitors like pembrolizumab can work. So I think this was a good move to then add this accelerated approval there. Now, there's a lot of questions here when it comes to precision medicine and testing. And I'm just going to touch base with some of what I think are the most important questions, many of which the answers are yet unclear, although I might give you some of my personal opinions here. So what genes really predict response to PARP inhibitors? I think it's still unclear. And the reason it's unclear is because testing for all these different studies has been done differently, right? And most of these studies, it's not been clear whether the mutations are monoallelic alterations or biallelic alterations. But I think what is clear is that BRCA2 is the most common alteration, and that tends to be an early alteration that occurs. And when you see it, you tend to have lost a second allele, and it tends to be a dysfunctional protein. So with that being said and done, I think we have a lot of confidence in this field that BRCA2 is really impactful and will respond well to PARP inhibitors. With other less common mutations, other genes, I think the jury's still out and more work needs to be done. What about circulating tumor DNA? Is that better or worse than archival tissue? And I pose both ways as a question, because one could argue that ctDNA is a real-time assessment. And if you have somatic alterations and new things are occurring, maybe if you test the archival tissue 5 years back, maybe you're not capturing everything. Okay, maybe new things have occurred, new mutations have occurred. However, at the same time, we have to recognize that the sensitivity of a ctDNA test may not be as good, right? You have to look at the allele fraction. It's tough to detect deletions in genes. And one thing that's clear is in some cancers like lung cancer, it's really easy. You know what mutations you're looking for in EGFR or ALK, et cetera. But in prostate cancer, these deletions can maybe occur 20% of the time in BRCA2, and they're subtle and hard to pick up. So we might be missing things. So this is yet unknown as well. Do alterations need to be biallelic? I pointed that out earlier. I think for a lot of these genes, it's different. For some, yes, it has to be a biallelic. And for others, maybe monoallelic loss is good enough. But again, the jury's still out. What about germline versus somatic? Well, we have lots of data now that shows that patients with biallelic somatic mutations can respond to PARP inhibitors. They can respond to immunotherapy. But theoretically, one has to think about it and say, well, if it's germline in every single gene, it should probably be, if it's a driver, a true driver, not just true and unrelated, a bystander, it should have happened early, and it should be in every single clone in the patient's cancer. And so it should work for a higher fraction of their cancer cells, where if it's acquired later as somatic, oh, who knows, maybe half the cancer cells don't even harbor that alteration. Now, that has not been proven. This is just all theory. But in breast cancer, there's a little bit of data that points towards germline patients respond better or have deeper responses. But yet, prostate cancer, unknown. What about VUSs, variants of unknown significance? Well, this is another one where you could take it both ways. You'll see these reports, VUSs, and that truly means exactly what it says. We don't know what that mutation means yet. In this day and age, we don't know, but hopefully it'll be tracked, and somewhere down the road, we'll find out. But again, this points both ways as well. For instance, there's a nice paper, I think it was in Science or Nature published, and they looked at VUSs and BRCA1. And they looked across the board and found that something like 80-90% of this VUSs actually led to dysfunctional proteins down the road. And so one would think that PARP inhibitors might work for those patients. But at the same time, a gene like BRCA2 is a huge gene, huge. And some of the portions of the gene are not as important as others. I talked to Colin Pritchards. He says, you could clop out, 70-80% of the gene right in the middle and paste the rest of it together, and it wouldn't even matter. So maybe if you have a VUS there, it just doesn't matter. So we have to be careful. We can't overreact to VUSs. We can't see a VUS and say, oh, better treat this patient with PARP inhibitor. We might not be doing that patient good. All right. And then the question about optimal disease setting, when to use PARP inhibitors. Well, right now it's for metastatic castration-resistant prostate cancer. For olaparib, it can be after abiraterone or enzalutamide. For rucaparib, it has to be after those and after taxane chemotherapy. But there are a lot of studies happening earlier. There are studies happening for unselected patient populations, for hormone-sensitive disease. I think we have to keep an eye out for it. But the one thing that we have to keep in mind is that even though these are oral therapies, they still carry toxicities, the myelosuppression, the subtle GI side effects. And of course, there is a tiny risk of myelodysplastic syndrome and AML. So we can't just say oral therapy, piece of cake, let's put it in the water early. So we have to do more studies, and that's ongoing. All right, I'm going to move on now to talking about the PI3 kinase AKT pathway and hepatocertib. And so this here, you can see the schematic here showing how PI3 kinase downstream is AKT, which has more functional effects down to mTORC. And P10 is a tumor suppressor that sits above that. So when you have P10 alteration or loss, which is quite common in prostate cancer, say 30% or so of prostate cancers, depends on how you look at it, what assays you use. But this should lead to PI3 kinase and AKT hyperactivation. And so it makes sense that we should be trying to inhibit this pathway, especially in patients with P10 altered prostate cancer. Now, there have been attempts with PI3 kinase inhibitors, earlier attempts, and attempts with TORC inhibitors, early attempts with some older agents that may not have been the most efficacious agents and have led to some toxicities. But this is with hepatocertib, a newer AKT inhibitor. And I just want to show you the updated data that occurred this year at the GU Cancer Symposium. So this is the Potential 150 trial, and it had co-primary endpoints. And what they did is they took patients who were asymptomatic or mildly symptomatic, metastatic castration-resistant prostate cancer, stratified them based on P10 loss by immunohistochemistry, and they randomized them 1-to-1 to abiraterone plus minus hepatocertib. So they had placebo and abiraterone, or abiraterone plus hepatocertib, 400 milligrams a day. And they had dual primary endpoints: radiographic progression-free survival for the intention to treat population, which was actually not statistically significant. As you can see, the p-value there is 0.0431. You might say that looks pretty good, but they set their statistical significance level for this cohort at 0.01. Okay, so that did not meet it. Close, but no cigar. For the P10 loss population, which is actually the population that one would think this should work well for, they did meet statistical significance because their p-value was set at 0.05 pre-specified, and it was 0.0335 there for this, enriched population of P10 loss patients. Now, the reason I want to bring this up is this was really presented last year at ESMO. So it's really outside this 1-year window that I'm supposed to focus on. But at GU ASCO, they presented this update. And the update is that even though pre-specified and for enrollment, they selected P10 no loss or not based on immunohistochemistry, this was an additional analysis looking at next generation sequencing. Why is this important? This is important because I just told you about all the reasons why we should be doing next generation sequencing for looking at DNA repair deficiency and PARP inhibitors, mismatch repair alterations, and pembrolizumab immunotherapy. Well, so it's important if you're going to get a panel, you're going to get information on P10. So it's important to recognize, do we need to do additional assays, or can we do one assay and kind of get everything we really need for our MCRPC population? And so the nice thing in this analysis that it showed is that it looked like by P10 loss by next gen sequencing that, the stratification into whether you're a P10 loss or not, and breakdown on response to hepatocertib with abiraterone or abiraterone placebo, it looks like the results are sustained and maintained, and it might be even a more robust selection marker for those that have P10 loss. So the reason I threw this in there is really to emphasize that we ought to be thinking about just panel testing. So to summarize, patients with P10 loss, radiographic progression-free survival can be improved with hepatocertib. Radiographic progression-free survival for the intention to treat population was negative in this first analysis. Overall survival data still pending. The next generation sequencing data lends further support to panel testing rather than developing a unique immunohistochemistry CDX, okay? I mean, we have lots of examples of these unique CDXs and they cost $3,000 or $4,000. And then the panel testing gives you a lot more information. Maybe it costs $5,000. What's more cost effective? Obviously to get more information. We now have multiple targets that support this as well. and that includes homologous recombination deficiency and immuno-oncology selection for the mismatch repair deficiency, MSI high genes, and hypermutation, tumor mutational burden, which is part of all these panels. They give you all this information. And so again, I'm sure there will be other things down the road, but if this eventually crosses the finish line, in the future, I think we might be able to use the next-gen sequencing P10 analysis. Now I want to move on to ACEs, and this is with Apollutamide and abiraterone versus abiraterone placebo. MCRPC, essentially kind of first-line therapy, randomized 1-to-1. Primary endpoint was radiographic progression-free survival and was positive. Secondary endpoints, I'll show you, not so positive. And so even though this was a New England Journal paper, it might lend credence to the idea that more is not always better. We always want to pack it together. We now have many, many different trials in metastatic castration-resistant prostate cancer. We're taking one agent that works and another agent that works. Maybe it doesn't always work better when they're put together. So that being said and done, radiographic progression-free survival was positive. It was a 31% reduction in radiographic progression-free survival, which was the primary endpoint. Okay. And this was the long-term follow-up, 30% reduction. So it looks very, very similar. But here are the key secondary endpoints. Overall survival, completely similar, almost overlapping. Okay. PSA response was better. You can see here, confirmed decline here was better. And undetectable PSA was also better for the combination therapy arm. But other pre-specified secondary endpoints, as I said, met overall survival, negative. Initiation of cytotoxic chemotherapy, chronic opioid use, pain progression, all negative. Clinical progression, these are exploratory endpoints now. First subsequent anti-cancer therapy, second progression-free survival, all negative, unfortunately. Here are the adverse events. Not surprising, combination, more, a little bit more fatigue, a little bit more hypertension, and of course, a lot more skin rash because we know that's a side effect of apalutamide. And also for grade 3 or 4 fractures and osteoporosis, it was worse. So again, positive primary endpoint, mostly negative secondary endpoint. So when is more truly more? I think although ACES was technically a positive trial for RPFS, I asked the question, is this clinically meaningful? What I would have liked to see are details on RECIST 1.1 symptomatic response rates to see if some subsets of patients have potential for greater benefit. Because if there's no overall survival benefit, I don't see a reason to do this combination. But if I had a patient that, let's say they had a visceral crisis, their disease is progressing really fast, okay? They're symptomatic and I want to induce symptom relief quickly, or I want to shrink some liver metastases quickly before they get into real big trouble. Seeing that data might have been important, but I didn't see that data, okay? Toxicity is clearly greater with the combination with abiraterone and apalutamide over abiraterone alone. I think the standard of care remains unchanged. All right, now on to what everybody wants to see is the VISION trial data. This is lutetium, PSMA 617, apt to change standard of care down the road. These were patients in the post-chemotherapy situation, 1 or 2 prior taxane therapies, greater than or equal to 1 androgen receptor targeted therapies, and protocol permitted for the control arm standard of care, which generally were glucocorticoids or switched to another AR targeted therapy. They excluded chemotherapy, immunotherapy, radium-223, investigational drugs, a lot of exclusions there for the control. So it wasn't the best control ever. You had to have PSMA positive disease on PET with gallium PSMA 11 PET imaging. And they were randomized 2-to-1 to lutetium plus standard of care, which is, again, dealer's choice, or protocol permitted standard of care alone. And there was no blinding. So that's important to recognize. Okay. So the alternate primary endpoints are really dual primary endpoints. They just called it alternate primary endpoints were radiographic progression-free survival per prostate cancer working group 3 and overall survival. And as you can see here, by PSMA PET criteria, you can see that about 8.6% of patients met the criteria. That means about 13 to 14% of patients did not meet their criteria, meaning they either had PSMA PET negative disease or they had one lesion that was PSMA PET negative and was quite large, okay, because they did have specified criteria. 83% of patients were randomized. Here's actually the criteria is that if you had greater than equal to 1 PSMA PET positive metastatic lesion had be eligible, and you couldn't have a PSMA PET negative metastatic lesion in the bone with a soft tissue component that was greater than equal to 1 centimeter, or in a lymph node that was greater than equal to 2.5 centimeters, or in a solid organ that was greater than equal to 1 centimeter. I asked the question, would this trial have been positive in a completely unselected population? You know, maybe, probably. You'll see the data here. So here's the primary analysis. Okay, and you can see very big difference there. Median improvement of around 4 months there. Very significant hazard ratio at 0.62. This is for all randomized patients for the primary analysis there. And then the RPFS analysis set here, you can also see very, very significant benefits there. Secondary endpoints, you can see a lot more patients that received lutetium-617 PSMA had complete responses, partial responses. So again, I don't love the schematic, but you can see it really points towards way more responses for those that receive lutetium PSMA. And here's the PSA waterfall plots, very, very clearly in favor of lutetium PSMA 617. All right, treatment emergent adverse events. Not terrible. Of course, one would expect that it would be greater, and it is for any treatment emergent adverse event for lutetium 617 than it is for standard of care alone. And the types of things you see here are fatigue, myelosuppression. That's not unexpected as it brings a radioligand therapy there to the tumor, and it can lead to leukopenia, lymphopenia, etc. But the unique side effects that the field needs to learn more about is dry mouth, xerostomia. And you can get some subtle GI side effects as well. Xerostomia is something we're going to have to spend a lot of time educating us as providers and patients about things to avoid to get through the xerostomia. Sure, there's artificial saliva out there, but that's gross, right? So we want to avoid using that for our patients. We want to educate them to avoid certain alcohol-containing mouthwashes, maybe have a humidifier in the room, to chew gum with xylitol in it. There's a lot of things that can be done. And these are things that I think that eventually as this agent becomes available, there's going to need to be a lot of education about it. I want to talk about the Therapies trial. And the reason is this was presented actually at GU ASCO. This was not a registration trial, but it's an important trial where the control arm was a lot more powerful of a control. It wasn't like switch to another AR target therapy or use of glucocorticoids. This used cabazitaxel. Now we know cabazitaxel in the CARD trial is already better than the switch to AR targeted therapy. So this was a really powerful control. And this was 200 patients. They had even tougher criteria by PSMA PET. And they had, 28%, which were selected out versus I think 13% in vision based on PSMA PET criteria. But they were randomized to lutetium 617 PSMA or cabazitaxel 20 milligrams per meter squared. And as you can see here, the primary endpoint of 50% or greater PSA decline, 66% versus 37% in favor of lutetium 617 PSMA over cabazitaxel. Secondary endpoint of progression-free survival. You can see at median, it looks about the same, but that's why it's a lesson and important to recognize the difference between the curves is the importance in the hazard ratio. It's actually a 37% reduction in the risk of progression with a very significant p-value there. And you can see the RECIST 1.1 responses, 49% versus 24%. Also efficacy looking in favor of PSMA 617 over cabazitaxel. Most importantly are the adverse events as well. And as you can see here, you get a little bit more thrombocytopenia with lutetium, but you get more neutropenia plus minus fever with cabazitaxel, and you get more xerostomia, as I mentioned, with lutetium, but you get more GI side effects with diarrhea with cabazitaxel. You get more dysgeusia with cabazitaxel, and obviously more neuropathy. So again, this is not going to be in the label, right? Because this is not a registration trial, but I think it's important data in a trial where the control was a powerful control using cabazitaxel. So my conclusions Adding PSMA 617 lutetium to standard of care in patients with metastatic castration-resistant prostate cancer after prior AR pathway inhibition and chemotherapy improves overall survival and radiographic progression-free survival. It's generally well tolerated. It has FDA breakthrough designation status. Hoping to see approval soon. Some questions: will gallium-68 PSMA or PYL PSMA PET positivity be mandated to receive lutetium PSMA 617? They use gallium PSMA. I don't see a reason why PYL PSMA wouldn't be just as good. Will chemotherapy eligible patients be able to receive this? Because in their inclusion criteria in Vision, they said you had to be chemotherapy not eligible. What does that mean? It just means a clinician talked to the patient and said, I don't think you're eligible. So, I'm hoping this stuff doesn't appear in the label. Does therapy help inform sequencing with cabazitaxel? Okay, if I was politically correct, very diplomatic, I would say that's not a registration trial. It's a randomized phase 2 trial. It shouldn't definitively inform anything. But I think it's a pretty powerful control, and I think it has to come into your thought process. Is there benefit to require combination with another agent, or will lutetium PSMA 617 be administered as a single agent? I'm not sure what the other agent was truly adding, but again, these are just my thought processes. Will there be practical challenges with administration? I think yes, we have to form good relationships with not just radiation oncology, which we probably already have, but with nuclear medicine, right? They're becoming a very integral part of prostate cancer imaging, diagnostics, and therapeutics now. I want to end with something that I think might be coming around the corner, the bispecific antibodies. These are really interesting. It's essentially two antibodies, for simplicity's sake, fused together. And the theory behind the use of most of these, they're not all the same, but most of these is the idea that prostate cancer has an immune exclusive environment and not a lot of T cells in the tumor. And so checkpoint inhibitors aren't going to work real well if you don't have your T cells there. So the idea is to help grab the T cell with CD3, an antibody that recognizes CD3, and then bring it to the tumor with an antibody that recognizes, let's say, PSMA. And so this is AMG 160, one of the few bispecifics with some public data out there. And you can see this is the early data. You'll see more soon. 68.6% mCRPC patients with any PSA decline, 34.3% with 50% or greater PSA decline. I think you'll soon see more data that's upcoming, but there are many bispecific antibodies being developed out there. This is the Harpoon trispecific antibody data. Very similar design, but they have an anti-albumin in there as well to try to prolong the half-life in the circulation, because that's one of the problems with these bispecific antibodies. In this, you can see these mCRPC patients, 50% with measurable CTCs at baseline had reductions, 14 had CTC 0 response, but you can see the PSA values, the spider plot, not the most dramatic spider plot. You can see with measurable disease there was, I think, target lesions in 56% were stable, but there was only one patient with a confirmed partial response per RECIST. So I think we need to see more data with this Harpoon agent. This is just a recent review that I published with one of my fellows that shows a table with all the ongoing bispecific antibodies that are being studied right now, as well as their Nccn clinicaltrials.gov identifiers there. They're in multiple different disease cohorts. And so just some questions. Exactly how does this technology work? I think we need to actually do metastatic biopsies, really look in the tissue. Are we seeing more T cells there? Do we have actual T cells in proximity to the PSMA expressing cells? We could do this with proximity ligation assays. I think we need more correlative science in these clinical trials. Are these T cells actually antigen specific T cells? Doesn't matter if they're antigen specific or not with this technology. What about PSMA PET imaging? How predictive is this capability? And most importantly is, what about mechanisms of resistance? And this is relevant also to the radioligand therapies that target PSMA. What happens over time when you develop resistance? Are you resistant to whatever payload it's bringing to the lutetium? Are you resistant to, the immunotherapy? Or are you losing PSMA expression? So we need to be looking at PSMA expression in patients that progress afterwards. Is the immune exclusive microenvironment even upregulated for these patients? And, what about antibody drug antibodies? That's an important thing, is if you see immediate responses, but then the responses are not sustained, is it that you're producing antibodies against those antibodies? And are there ways to quell that? I think that there are, but that needs to be studied. And, obviously with, adoptive T cell transfers, CAR T cells, antibody drug conjugates, there's all kinds of potentials for future combinations. So here are my parting thoughts here, and then we'll take some quick questions and answers. The here and now, PARP inhibitors are here for those with BRCA gene alterations and other homologous recombination deficiency gene alterations. Pembrolizumab for those select patients with mismatch repair deficiency, MSI high tumors, tumor mutational burden high tumors. Biomarker testing has a lot of issues, but we're learning more, and I think panel testing is the way to go in the future. More is not always better. Combination therapy sometimes just adds toxicity and not enough benefit to warrant those toxicities. The near future, I think lutetium PSMA 617s likely to see regulatory approval in the near future, and our patients will welcome that. And in the more distant future, I think bispecific antibodies have some intriguing promise. So with that being said and done, I'll wrap up and turn it back over to Judd right now.
Evan, that was wonderful. Thank you so much for that. My head is spinning. I mean, there's so much new stuff going on. I think we have time for maybe one question, but I put this slide in at the end when we were supposed to be live. What happens in Vegas does not have to stay in Vegas, especially related to our topics today. I'd like to ask Dr. Karsh, the one question that came in about costs of Enzolutamide, Apollutamide, and Darolutamide. So maybe Larry first, can you just comment about costs and how do you, from a practical standpoint, prescribe these agents in your practice?
Well, these do have a significant cost, but they are approved by insurances. If you go by guidelines, insurances should cover it. Now, it goes under Part D, which is different than Part B, where you get your GnRH analog therapy. But there are foundations. Our nurse navigator gets online and gets foundation money. It really depends on your secondary coverage for Part D. Some patients can pay as much as $6,000 per year with that donut hole. But, these things are somewhere between $10,000 and $12,000 a month. So they are expensive. But if you shouldn't have a problem getting insurance approval if you're within the guidelines. So they've got to approve it. And Medicare will approve what's ever, been approved by the FDA and in the guidelines.
So guys, I'm so sorry. We're getting the hook from the AUA. So we're slightly over time, but again, I want to take this opportunity to sincerely thank Dr. Karsh and Dr. Yu, two amazing presentations. Again, it's a lot to think about, a lot to learn. We hope to be able to come back to you live next year at the AUA and continue the discussion. But again, for everyone who's joined us this afternoon, thank you so much and enjoy the rest of your AUA.